Maria's gonna take us through that. Not roll call vote, roll call attendance.
Okay, are we rolling, Joseph?
Yep.
Okay.
Oh,
Oh,
Mr. Romero.
here, look through here. It's gotta be somewhere. Okay, this is the REMAC New York City meeting, September 12th, 2017. Please answer if you're here. Don't if you're not. Welcome back from summer. It was too short. Robert Winchell.
here.
Joseph Schenker.
Here.
Michael Batch. Robert
Yes.
Ackerman. Michael's here?
No, he's on the phone.
Oh. Robert Ackerman. Nicholas Alexandru, I think, isn't he?
He's deployed.
He's
Draw up a
deployed.
quarter of it.
Christopher Graziano.
How much is in the bottom?
Eric Cohen. Mimi Langsom. Kevin Munjal.
Here.
Cindy Bassos. Here. Dario Gonzalez. Is he deployed too, or he's just not here
He's,
today?
illness.
Okay. Glenn Esteta.
Here.
Bradley Kaufman. Doug Isaacs.
He's deployed too.
What do you think to get out of arena? Nathan Reisman.
Yeah.
Joshua Buckland. Talina Lloyd.
Present.
Hi, Talina.
Hey.
Jeffrey Rabrich.
Here.
Heidi Cordy.
Here for Heidi, as you said.
Louis Marshall.
Here.
Michael Redlener.
Present.
Michael Hilton.
Present.
Michael Gutenberg. If Mike is recovering from surgery. Pamela Lai. Dominic Battinelli.
Here.
Scott Chang.
Here.
Peter Wire.
Here.
Paul Barbara.
Here.
David Benelli.
You're right.
Celia Quinn.
Here.
Timothy Stiles. Charles Martinez.
Present.
Joseph Bove.
Present.
Martin Grillo, who's not here, it's his birthday, he took off. Matthew Isaac Harris.
Matt Harris.
Stephen Blumberg. William Fisher.
Here.
Robert Krupe.
Here.
Jessica Van Voorhees.
Here.
Arthur Cooper. Gary Marshall. Yadidja Langsom. Anthony Shalish. Christopher Sorrentino. Let me just make sure we have a form. Yes, we have definitely more than a quorum.
Okay,
No, you can't go home.
welcome everybody to this new year of our REMAC meetings. We did not meet in June because we did not have a quorum, so we're going to have to take a step back and approve the minutes from the April meeting, the April 26th meeting, followed by the minutes for June, and then we'll get to the minutes, we'll get to today. So the minutes for the April 18th REMAC meeting, anybody have any questions, concerns, comments? Motion to approve, second? Thank you. So that's the motions from April 18th. The minutes from June 6th, they just indicate that we did not have a quorum. So that's going to prove that. Great. All right, the correspondence report from June 6th. There's some stuff I have to read into the minutes here. Public notice from the Department of Health, EMS Operations Unit, Matthew Agrona, EMT number 427-658 received a $1,000 civil penalty for violation of 800.16. He resides in Buffalo. This is from June 6th. Elmhurst Hospital, I don't know if they have finished their ACS COT visit. They had to have it done by July 5th. I don't know if that was done or not.
We haven't
Get
gotten
any further
anything.
information?
No.
The check and inject kits are available from Boundtree. The training material is available at www.mlrems.org/checkandinjectny/checkandinjectny.asp. Okay. And there were two advisories that were sent out. One were both about drug shortages, dextrose and sodium bicarb, and then a repeat dextrose and sodium bicarb. I will discuss these a little bit more during the executive committee sub-report. Okay. Correspondence from September 12th. There was no public notice that needs to be read in. Dr. Simon requested that we add STAC and DOH pediatric guidelines to the REMAC agenda going forward. We will look at that under new business if we can get to it. If not, we will add it to the agenda going forward. We got two correspondences from New York Presbyterian. One was, and I'm going to take them one at a time. I think there'll be some discussion, so let's go one at a time. The first one was in reference to the mobile stroke treatment unit. And I know that the team from New York Presbyterian, Dr. Fink, is here. I'd like them to give us a little more information, but the essential correspondence that we received was that they would like to expand their program from the one ambulance that they have to a total of 3 ambulances in New York City. Okay, let's start with that point. We're going to discuss that. And like I said, the team is here in case you have any questions for them, and then we'll take the next point in that correspondence. Any discussion about the program expansion? All right, I like that. So that'll move pretty quickly. The second component of that correspondence was that they intend to use a telemedicine model on these stroke ambulances. Not to provide telemedicine services to the paramedics, but to an advanced practitioner on board that would do any of the advanced skills that are out of scope of the paramedics on that unit. So that unit is a regular ALS unit. It would be staffed with an advanced practitioner who would then, speaking to a stroke neurologist, have a telemedicine encounter. The stroke neurologist with the advanced practitioner would make the decision to scan and administer TPA to the patient if that was indicated, and follow that guideline. Any discussion on that component?
Just to clarify, what is advanced practitioner? What's that?
An advanced practitioner is a PA or a nurse practitioner. Yes.
Can you forward these to the committee so we can review them?
The letters?
Yeah.
Sure.
I mean, they want us to consider this, so we should review the letters.
Again, the letters were just, the letters come to the council and are just presented as part of correspondence. I can read you, the other letter I'll read to you, but they essentially get presented as a letter stating this is our intentions, and they come to us for discussion.
Have they, maybe you're planning this later, sorry, I have not heard of any feedback or data from the initial ambulance or the initial patients that we've seen, and I think, I'm sure you want to hear kind of how that's gone to this point.
Sure. So we did have a meeting that was before the June REMAC meeting with the QA committee, where they presented the data they had to that point. That wasn't presented in June because we didn't have a meeting, but we were going to present it tonight here at this meeting. But Dr. Fink and his team are here. I think if we have any questions, we can address it to them directly, and then we can go over the data that was submitted as well. Mike can discuss that as well.
Thank you, Dr. Schenker. Since you have not, we presented this, the data up to June to the Quality Assurance Committee, I'm sorry that you didn't all get that information or see it. We can put this up on and project it if you want to see it for the whole group. Can we do that?
Yeah, sure.
Okay.
Hold on.
Let's plug it into
Joe?
a flash drive and we'll show you. And this will be an update
Can we
really
get another,
for the, up until the end of August. So there'll be a
Can you
further
plug that in?
update.
We just have to put something on the screen. Oh,
do we have another upstairs in the office? You could pull it off my computer.
I'd have to go upstairs and grab.
no, we just need another power cord.
Well,
You have a power
okay,
cord?
so instead of doing
Give
that-
us 5 minutes.
To plug two things in.
Okay, this, Dr. Lorario is the medical director of the program. He lives and breathes this information, and I'm gonna let him present without the PowerPoint, give you the data about the outcomes of the program, and then we'll be happy to take and answer any questions you might have. If I can add on in anything if you want me to help, but Michael, why don't you go ahead?
Yeah, no, we've been very excited to see some of our data being analyzed. Basically, for our first a little over 10 months of operations now, we recently analyzed what our treatment times have been and some of the other data that we've been collecting from the patients we've treated on our ambulance. So we've treated 31 patients with TPA so far on the MSTU. 3 of those patients were transported by the MSTU and treated in the emergency room. But what we've seen is that very significantly, we're having shorter treatment times from onset, when stroke onset occurs, to when we get the TPA into the patient, and additionally to when the MSTU is dispatched to when we're treating the patient, and lastly, when the MSTU arrives on the scene to when we're treating the patient. And we've just recently reached statistical significance when we're comparing that to our standard ambulance transport on standard ambulance transport to the Cornell and Columbia campuses. This is also within range of what we're seeing from national benchmarks from places like the Cleveland Clinic, Houston, and international benchmarks from Berlin and other areas of Germany. In total, the most probably telling statistic is our onset to treatment time, which is about 40 minutes faster on RMSTU compared to standard transport in the emergency room. So this is very
Let me repeat that so everybody hears it clearly. This is a very important number.
So onset to treatment time, from symptom onset to when the TPA bolus is provided to the patient, we were able to get 40 minutes faster on our mobile stroke treatment unit compared to standard ambulance transport to Cornell and Columbia. And those campuses are already, as we all know, very fast and efficient in treating in the emergency room.
Yeah, and what we've discovered is that a large proportion of patients now are receiving thrombolytic therapy within the first hour, which is almost unheard of in patients who come to the various emergency departments of hospitals. And we're seeing recovery occur more rapidly than we've ever seen before in terms of recovery en route to the hospital in the ambulance or shortly after the patients arrive. So the benchmarks we've attained actually exceeded what our original goals were. Our original goal was to try to reach a benchmark where we would reduce time to treatment by 30 minutes, and we've actually beat our own targets in doing this. Michael, do you want to talk about, any issues or problems, complications? I mean, everybody wants, of the 31 patients we've treated, only one of them, 1 out of the 31 has had a hemorrhage related to administration of the thrombolytic. And that's well below the standard expected number, which is somewhere between 3 and 6% of patients treated with IV TPA are expected to have hemorrhage. So we've had 1 out of 31. We've had absolutely no problems, medical problems associated with doing this on an ambulance. Nothing. There's not been a single problem. We've had a few technical problems with the ambulance itself. The engine didn't start one time, the battery ran out, things like that. But in terms of
I blame
medical
Dan.
treatment, it's not their fault. It's just
No, but I blame him anyway.
Yeah, just mechanical stuff. But in terms of the medical treatment delivered to these patients, there has not been a single problem of any sort. Not a problem with an IV, not a problem with an EKG, nothing. It's all worked absolutely perfectly. So, all right, Michael's got the slides up. So,
And certainly the idea of expanding this program, one imagines that your numbers are only going to be
even more impressive when you're not in the epicenter. I mean, Manhattan being the center of the universe in terms of stroke centers, minutes to a hospital being very short. Imagine that when this, the expansion of this program is only going to be even more impressive improvements in time,
Yes,
onset.
and so the second ambulance has been already reserved for Queens. We think Queens is the most underserved borough when it comes to this kind of care. So Queens is going to be the next one. The third unit it's being discussed at the moment about where it should go. So I don't want to give you anything definite about that because it's under discussion. The second one will definitely be going to Queens. And if you're wondering about who's paying for all of this, the cost of these 2 additional units are being funded by a foundation that we apply to, and they're providing funding to build and operate these next 2 units. So this entire program is running on philanthropic gifts. It's not hospital operation funds, it's not city funds, it's all out of philanthropy. We understood from the beginning that that's the way this was going to have to go.
Correct.
So, okay, Michael, I'll let you show them the rest of the day.
Sure. And I think, another thing to just point out again is that this was the first program on the East Coast. And since we've launched, there's been some other centers that are nearby, including Trenton, New Jersey. These are this type of care that's really expanding throughout the country that we're really pioneering here and championing. Our first TPA patient was back on October 4th. This was our clinical team at the time. And we've had multiple patients now treated within the golden hour of thrombolysis. We've seen from other centers that treating patients within 60 minutes of stroke onset is quite common in mobile stroke treatment unit. And it's something we don't standardly see in the emergency room. And this again just showing how powerful this treatment is, that we're getting to patients within an hour of their stroke symptoms starting. And this patient was treated quite fast. This was our first case, and our times have even improved since then. But we were able to treat this patient very expeditiously. This patient was discharged home without any disability back to their baseline. And we have many cases like this now at this point. But in aggregate, we're seeing a very large clinical volume. Obviously, we're not transporting every patient we see. They're not all appropriate, but we're transporting a large number of patients and definitely maintaining feasibility even in a very dense area like Manhattan. I think that's another thing to stress too, is that this is probably the densest area that we're actually having mobile stroke unit care in terms of population, in terms of amount of stroke centers, and we're seeing the same outcomes that we're seeing elsewhere in the country and the world. This data is through August 15th. The 40 minutes that I quoted you before was more recent, but obviously can change with the number of patients we treated. But you can see even then, the onset to treatment time from the onset to treatment time with TPA is even more staggering and impressive here. 130 minutes within our 130 minutes within our emergency rooms compared to the mobile stroke treatment unit, which is 81 minutes. And then almost over a 20-minute time difference and almost a 30-minute time difference from scene arrival TPA and 911 dispatch TPA. So very large differences in times that we're seeing with mobile stroke care, and these have now reached statistical significance within less than a year of us starting operations. We've had good discharge dispositions of our patients, definitely within what we would expect from national standards that are published in the literature. This is just discharge disposition, and in terms of patients that were discharged home, which is almost 50% of our patients, acute rehab or home with services, when you add that all up, we're talking about 80% of our patients are having a good discharge disposition, and that includes the patient that did have, unfortunately, that ICH event. So these patients are doing well, they're going home, they're having good outcomes. These are just some of our other operational metrics. These have continued to improve over the last year, particularly in terms of the time of CT completion. We're getting faster, we're getting better, and we expect this to continue to improve as we expand the program and grow.
Michael, hold that slide
Yes.
for a second. We presented earlier data to Dr. Red Leonard's group. I don't know if you remember. You that CT arrival to CT completion time, when we presented to you back in June, was over 40 minutes. And we said to you at that time, our goal is to reduce that time by 10 minutes, because 40 minutes is too long. And I just want to point out that we reduced that time by 10 minutes, which was what we planned to do, and I just wanted to point that out. So we're very focused on trying to improve the processes at every step of the way, and this is a good example of how we did it.
Yeah, that's a great point. We've started doing a workflow where we're going straight to the CAT scanner, which is expediting the whole process, getting the TPA times faster, and we're just learning from other groups and with our own experience here. This is, we want to even get this even lower and get these TPA times even faster, which I think we can achieve. But this has been the one case of the symptomatic ICH. This is from the NINDS trial, which was 6.4% risk of symptomatic ICH with TPA administration, and we've had one case now out of 31, which is less than 3%. So what we've been seeing is that our volume is really maintaining the feasibility of the program, that our treatment times are showing that this is effective, it's now reached statistical significance, and that we've really proved that this concept works even in combatants, and that these patients are getting faster stroke treatment, and that's going to result in better outcomes. And we just really want to get this out there to the city, to as many patients that can really get this great, new innovative treatment. And then we've been having some great press. This is from our external affairs team. I'm not sure if people have seen out there, but we've had press releases through WABC, through the New York Daily News, or we actually newspaper and print, and then through our local site as well. We're releasing a lot of great press on our patients that we've treated that are extremely eager to come back and advocate for this new technology, and they're speaking on this and how great this was for them. Patients that were phasic, disabled, now speaking completely normal back to their baseline because it's excellent treatment.
And there's one more collateral benefit that has come from this. We discovered that by evaluating patients who come to our emergency department, that less than half of the stroke arrival patients come by ambulance from a 911 call, which surprised me. I kept thinking people would be calling 911. Apparently they're not. So all of our stroke doctors have been blanketing the city with community talks, every possibility. It could be a corner store, churches, synagogues, community centers, whatever, to get the message out again to patients. If you have stroke symptoms, call 911. You got to call 911. So we've been very aggressively doing that again because we discovered that people are not calling 911 as much as they should. So I'm assuming that that's going to have some effect in terms of the number of calls that are going to come into the 911 system.
Thank you guys very much. Any questions or comments for the team? I know Paul first.
Paul Barber from Staten Island. Quick question, the outcomes. Can you go back to that, because I got distracted when you were showing that.
Are you distracted all the time?
Well, you distracted me. Where's the comparison to the non-MTSU patients? That's my question.
This we were comparing to national published data, so including journals like Stroke and other very high-impact journals. We have data on what patients who are treated in our hours of operation with TPA usually have in terms of discharge disposition. And that ranges for good outcome, which is usually homeless services, or acute rehab, usually ranges between 2/3 and 75%. So this is definitely within the realm of what we expect. We are later going to analyze and compare it to standard patients, but in terms of the treatment times, we have done that, and that is very significantly different.
Because I think that's what many of us around the room want to know, is that the deployment of this, this device and earlier earlier treatment times, and you're cutting the golden hour of fibrinolysis. If you're going from 65 to 75 to 80, that's not a huge jump for the extra hour of fibrinolysis.
Yeah, well, I think with the great time impact that we're having, it doesn't take many prevented disability outcomes in order to have a large, cost-effective, and to clinical benefit.
So the morbidity alone is enormous, we all know that, but
Yeah.
that's what we're looking for. We're looking to improve those 3-month outcomes.
Yeah, and that's why we want the more volume, because I think that's what we need. These outcomes are delayed 3 months.
Certainly. And
So with our small volume, that's something that we
So
really.
we're collecting that data along with other centers around the United States, because the numbers are gonna be too small.
yeah, and a 25.
Yeah, it's gonna be too small just in Manhattan, or maybe even for all of New York City, to make a statistically significant, valid difference. But to do that, it's an IRB-approved protocol. We gotta collect the data. We can't release it or analyze the data until it follows the protocol we collected. So we're doing it with, we're gonna collect data as part of the national study, New York City, Memphis, Houston, Denver, right? Those are the cities. LA as well. We're gonna collect it for 2 years and release it and analyze it after 2 years. So I don't think we're gonna be able to show it to you until we hit that point. So everything we're doing here is to make sure that we are not seeing any increased adverse events, and that we're on track in terms of looking at these kinds of outcomes, that we're at least in keeping with what is considered to be good outcomes at time of discharge.
Jeff?
So I was going to ask something similar along those outcomes, and I think if you look at what you've done so far as kind of like phase 1, I think you've really demonstrated well how you can reduce the times, and as far as your harms data, I think you've shown us that, you know, the one bleed is pretty good. I think expanding the units gives you an opportunity to get what we really want to know, which is, are these patients really that much better at 90 days compared to the standard? And you may get there faster with the additional units, but I think, you know, what you've shown us so far, at least to me, demonstrates that the safety of this approach, and that you know, it doesn't appear to be any harm that's being caused.
Yes, thank you.
Yes.
Do you have the demographics of the patients that were treated, age, gender, comorbid conditions?
Not on us.
We have that data, we haven't collected or analyzed it, but we do have it. We do have some of that in the medical records.
Any other questions for this discussion? Yeah, Mike?
Thank you for presenting, and you know, it's funny, we haven't had a quorum in REMAC for a while, so we haven't had a chance to share the data with the committee as much as we would have liked to. So what I would say, I think from both the QI presentation and from today, I think what we're seeing is that you have good safety data, you have shorter treatment times, and you have less numbers than you would have expected from when you proposed the project in the beginning. I also, I think we're all interested in the clinical data, and I think we're interested in kind of figuring out you answered a lot of the questions that we had from the initial presentation as well around the operational pieces. And so I would say in general that I feel comfortable with the project and the way that it's moving forward. You know, I have some questions about how we'll do the operation, we'll do the telemedicine and that type of thing. So I look forward to kind of seeing a little more detail and talking about the final project presentation about that. So thank you.
Any,
Dr. Fink, if you come to Brooklyn, we'll double your volume.
Well, I think, you know, my feeling. My feeling is I would like to come to Brooklyn. Okay, first, you know, but a group has to discuss it and decide it. I can't just decide.
so, I mean,
I would like to come to Brooklyn.
hearing the discussion, and there's been some great points raised, I think that overall, you know, they've demonstrated the safety and efficacy of this, and obviously the larger N is gonna provide for more data and more information to see what the true benefit is. So I guess at this point, I'd like to manage this first part of their, yes, I'm sorry, Kevin.
Sorry, I had a quick question if I could maybe ask somebody from the fire department just to comment on, you know, is the fire department involved in decision-making around sort of neighborhoods? I know that lots of previous times when discussions about pilot programs come up, issue of equitability and things like that with different neighborhoods comes up. So if somebody can just add a little bit more information about that.
Sure. You know, as you know, the stroke unit has been going between Hospital 14 Cornell and Hospital 17 here at Presby, so they're getting a little mixture of different neighborhoods. We've looked at the numbers as well. We've been kind of tracking that, and there, I know the 31, I actually have 28. There's 2 additional that you actually transported, but the TPA was given in the hospital, from my understanding. If you're 31 now.
That's
it's probably not.
28 in the ambulance and then